All right, we are recording. Welcome, everyone.
Oh, welcome. So my name is Chris Wilson, and I'm joined by Ann Henshaw, and we're kind of the co-developers of this, this really inspirational group of what we've kind of titled American Palliative Rehab Alliance. It's an interdisciplinary group really designed to advance palliative rehabilitation as kind of a standard of practice. And really our goal is that when someone's facing a life-threatening illness, that access to rehabilitation services and similar providers is a human right. And that's really what I think we need to kind of keep our focus on. So we were going to kind of start off with a little bit of our conversation and just kind of go over some of the things that we've been kind of thinking about and kind of familiarize you with at least the start to a website. We've been kind of starting a little bit of a website. So maybe I can share that first, and then maybe Anne, if you want to talk a little bit about what we were kind of figuring for our next steps, that might be a good way to go. So let me see if I can share my.
I think I've allowed you to share. Let me know if you can't.
Let's see. I think you did. Thank you. All right. So we have a website. So if you go to palliativerehab.com, it will bring you to our website. It does change to a Google site. I don't know if you all knew, but you can use a Google website for free, which is exactly what we did, because this is, again, a labor of love, and we don't have any funding for anything like this. So what we're really kind of envisioning is that at the top, you can see we would have resources. So journal articles, books, any websites and media. So what we're really looking for is things that you've written, favorite articles, presentations that you maybe have done, YouTube videos that you're aware of that you love, that really kind of speak to palliative rehab. And then we'll be able to post them on here. Right now you can see under articles, we've just kind of started by doing it articles by healthcare specialty, and then we've kind of gotten some stock photos in here. And then of course we'd be adding more and more disciplines. So please keep in mind that if you don't see something, especially if it's related to your content area, it's not intentional by exclusion. It's just that we just have not built it yet. So we're kind of, Ann and I are OT and PT, so we're leaning on what we know.
Mm-hmm. And we ask all of you, if there are articles, either brand new ones that just came out that we may have missed, or just articles within your specialty that are, sort of the article to go to, please share. Hopefully we're culling most of them, but we certainly could have missed some.
Yep.
I know for the OTs out there's a group that meets, and they have a toolkit that we're going to be adding to our site. So, but there's probably more.
And just for the sake of convenience, so I clicked on the OT articles, and we actually have a couple of authors from our first from the first article. And basically this is a Google Doc, and we're going to have the DOI on there. So again, the more that we have those, and maybe we can kind of start subdividing those. We do have, Ann and I do have two student graduate assistants from Oakland University who are going to be helping us to collate and correlate some of this content into it. But certainly we welcome what your ideas are. And if you have other things that need to be on here, we certainly will be doing that. And then we've got a couple of temporary placeholders of like some of the articles by topic. So maybe they'd be, cachexia or, end of life, or whatever other topics where rehabilitation professionals might need to get in. And I think that's probably one of the things that we'll have to kind of be careful of is that it's not just all of palliative care, because there's lots of palliative care websites. It's what do we bring uniquely, kind of that palliative and rehabilitation. And it might end up being diagnosis specific. So we might be, you can get a lot of palliative care COPD rehabilitation articles or something like that. So so we'll kind of have to work through that a little bit. And then we'll do the same thing for books and websites and media and events. This is our pretty much, I would say, our first official event that we're going to be recording and posting on here, and we'll be posting it out as well. So thank you, Lubayna, for kind of being our first volunteer for this. You're helping us make history, which we're very excited to have you as such an esteemed speaker first. And we also realize that, people are going to potentially not be able to make every meeting. Everyone's such busy with family and careers. So we do have strong intentions of making it synchronous and asynchronous at the same time. So if you can't be in a meeting because you have other things, it's a sports game for a child, or, you know, you had to work late or something like that, you're still not missing out on any content. And then at some point we did put a placeholder. Maybe there'll be some on-demand courses that we do have some great content experts that could help host or even promote external audience courses. So if someone's doing a course at a national conference or something like that, that maybe we want to post into here, we certainly can do that. So, and then we have some other ones. So like for patients and families, just in case someone Googles palliative rehab and wonders what it is, that there would be, you know, one for adults and one for young adults and adolescents. And we've kind of got a little bit of, you know, what's the difference between palliative rehab and palliative care? Does my child need palliative rehab? So again, lots of placeholders right now until we can kind of start getting some of the content solidified. And then we do have students and new professionals. I think the students were very excited to help us develop this part. Is really kind of getting the students kind of excited and involved, and even just knowing what this area of practice is, and how, you know, how in some cases it's very similar. You know, the treatment skills aren't always that much different, but sometimes it's very, very different. And sometimes the focus is very, very different. So, you know, we do want to make sure that we're speaking to that audience. And then, you know, at some point, maybe for policymakers, you know, we might be able to kind of have some, you know, white papers or statements that we might want to make and say, hey, this is really important. You know, this is what we think, and then be able to forward that to them when they do make policy in that area. So again, we apologize profusely in advance because it's still a work in progress, but we're excited that we have a work in progress that we're kind of starting to work on. So,
Chris, do you want to back up and introduce our wonderful research assistants in case people get emails from them? I thought I saw Emily, but
no, I think I'm looking for Jordan.
Okay.
Jordan and Alicia aren't here yet.
Okay. Oh, that's okay. Neither of them are here. Okay.
Yeah, they're not here
I thought
yet.
I had seen
But
one.
they might be showing up a little bit
All
later.
right.
So
No
maybe at the end
worries.
of the meeting.
No worries. Well, you could maybe let them know the names, and that way, in case they hear see emails from them.
Yeah. So if you get an email from Jordan Humitz or Alicia Nacarado, they are our grad assistants, and we're going to give them a cool title or something like that. You can put on the resume, like, you know, co-executive directors or something like that. It'll look really good on their resume, even though they're just grad assistants right now. Not just, but you know. So let me stop sharing, and then you know, maybe we can even open it up to any comments, thoughts, or ideas, and then we can kind of talk for a few minutes about you know, kind of the next steps, and then we can have Lubayna present.
And we would appreciate if people have time to sort of look through the website and even just see if the placeholders make sense. Maybe we're missing some gaping, you know, something we've really totally missed. Maybe it's equipment, maybe, I don't know what it is, but I guess just sort of, we appreciate any feedback. Take a look, just see what you think, and see, again, we are open to ideas. And also, Emily is an OT. The two students that Chris mentioned are PT students. Emily is an OT student who is doing a capstone in this space and doing some gathering of information as well. Hey there. So that we, you know, if these folks reach out to you, they're helping us build this, this whatever, this beast. Hopefully a powerful talking. Somebody will listen to us that makes some policy decisions, really, as well as supporting one another. And building bridges. I mean, I started this really with the concept of building bridges between the departments, between OT and PT and speech and palliative medicine and music therapy and all the folks that matter to people that are suffering with serious illness. So I'll stop talking, and we're going to open the floor. Thoughts?
I know you all work in palliative care, so none of you are shy.
Yes.
So while people are kind of thinking about things, so the other thing that we're going to be looking for is, as a general rule, I think we decided that we were going to try and meet kind of as a big group about once a month. And we basically were kind of talking about doing a kind of like the fourth Tuesday of the month. Is that what we decided, Ann? Does that sound familiar?
I believe so. I'm just looking through my notes. Yeah, I believe that was right. Yes. For the big group. Mhm,
Yep, exactly.
yep.
Yeah, so we're gonna probably have a similar meeting like this on June. Let me see what the date would be. It would be the 27th. Would be theoretically our next meeting, so you can save the date for that. And we're looking for someone who might be a good person to speak or guest lecture on a specific topic. So, it doesn't
Short.
have to be.
Yeah.
Yeah, and what we're trying to do is kind of do exactly like this framework is have, 15, 20 minutes of chat and kind of like a business meeting, for lack of a better term. And then the remaining time, try and keeping the meeting to an hour to respect everyone's time, kind of have a presentation by a person in an area that they might be, have some experience and to lend some information or inspiration to the rest of the group. And then we're also looking for probably about 3 steering committee members. So we want to, 5 is a good number. You don't want an even number just in case there's votes. You want an odd number to break the tie. So, basically that we were talking about that steering committee probably to meet on the second Tuesday of each month. So we're looking for people that might want to kind of join and in on that, and just kind of be on a little bit of the leadership team, kind of with a lot of these things that it takes a village to grow things. And we don't want to put anyone on the spot right now. You don't have to let us know, but you can email Ann or I, and then just let us know if that's something that you'd be interested in. We don't really have, there's no job description yet, so that might be kind of one of the things we're working on. It's kind of a little bit of what a job description. I won't say the pay is great. It's all volunteer. We're all doing this out of the goodness out of our hearts, because we see a problem with the healthcare system and we want to fix it. And we really love working with this patient population, and we want to make it better for those folks. So, if you do have a little bit of time to spare, I don't think it's going to be probably much more than, an hour or two a month. For me, that's like, okay, I'll binge 2 less Netflix shows or something like that. And I'll do something fun like this that really kind of helps to move practice and give clinicians the tools to be able to do their job to work with this patient population. So,
and if you're interested and Tuesday's not your job, also let us know that. We're not wedded to that. We are just, that's what we talked about as a small team, but would really like, really multidisciplinary approach. I'm looking, I don't think we have our music folks or the speech therapists that we've been. So if anybody knows any speech therapists or music therapists or anybody else, sort of a chaplain, that might work in this space and might be interested, we'd really like it to be multidisciplinary. And I think that's a big focus for us.
Yeah, and then don't be afraid to volunteer your colleagues if you've heard some of them speak before.
Yep.
Give us their information if they're okay with that. Then we'll politely ask them to present by invitation. So yeah, so I think that's all that I had to. Oh, go ahead. Thought I saw Shay was going to say something, but maybe not. All right. Yeah, so welcome everyone. So I think we are just about ready, unless there's any other comments or questions or thoughts, that we'll have our esteemed speaker, Lubayna Fawcett, who she and I kind of go way back from talking about palliative care from the physical therapy end. And we did email out her bio, but Lubayna, if you have anything else that you want to share about yourself, and certainly some of the important the work that you're doing, that would be very welcome. And thank you for being here.
Thank you so much.
Thank you. So I want to share this screen. How do I go about doing that?
The bottom middle, you should be able to. I have everybody can share.
So should be a big button in the middle, the green
Share
one,
screen.
Share screen.
At least for me, it's bottom middle and it's green.
Bigger so I can see the rest of the screen.
If it's easy to do, I'm happy to have you email it to me and I'll share. But if Up to you.
Okay, I got it. I had
Okay.
to open the, and so on.
It's coming up. We see it.
Wonderful. We got it.
Guys able to see that?
Yep, we can see it.
Okay. All right. So good afternoon again. So this was my presentation. The title was Physiotherapy Palliative Care Integration in the Zimbabwe Universal talk in September in 2019 in Kigali, Rwanda, at the 6th International African Palliative Care Alliance. This organization meets every 3 years and works in partnership with the Worldwide Hospice and Palliative Care Alliance, which is based here in the US. What's of interest of this conference is that during the 4-day conference with hundreds of attendees and several, equal numbers, probably in 100 US, there wasn't a single mention of palliative rehabilitation, not one. No PT, no OT, no speech, no nothing. And this was an eye-opening for me, underscoring the enormous work that needed to be done by the rehabilitation professional bodies to become members of the palliative care services. In other words, to be at the table. So disclosure was none. I had more or less 4 objectives in this presentation. The first is to delineate the advocacy strategies and the processes that made physical therapy be included in the Zimbabwe National Palliative Care Integration and the Universal Healthcare Coverage, as well as share the outcomes and the lesson learned and provide summary and recommendations. So initially, we just did the definitions, defining what universal healthcare coverage means, which I know in the United States is something that doesn't exist, but it's a human right in terms of healthcare in promoting, preventing, curative, including rehabilitation and palliative healthcare services. Also, defining what palliative care is. It's all about quality of life and the effectiveness of approaching life, including those with serious illnesses and end of life in a multidisciplinary, holistic way to address all their concerns as much as possible. It is also what physiotherapy is. And I'm interchanging physiotherapy, physical therapy, just because in other parts of the world, physical therapy is not the term that is used. We use physiotherapy. So just understanding what physiotherapy is and how we fit into the bigger picture of the palliative care. And overall, what we do in everyday basis is to improve the quality of life of persons that we work with. As well as acknowledge the Lancet Commission report that was done in 2017, which identified physiotherapy as an essential component of palliative care. I know I'm talking mostly from the perspective of physiotherapy, but that's what my focus was. But whenever I say rehabilitation, I'm including all the allied health professionals, including all of you, my colleagues, in this meeting. And the impetus in doing this was the support that I had, mostly from the African Hospice Initiative, which I was fortunate to be a board member. Island Hospice and Healthcare, this is the oldest hospice in the continent of Africa. It was established in 1976 or 78, I believe, in Zimbabwe. Initially, it was set up for cancer patients. And then later, as the HIV epidemic became prominent, then it included that as well as other diseases as non-communicable diseases. It seemed to be increasing worldwide. And the founder of the African Hospice Initiative was Dr. Barbara Glazier, and she's the one that has been funding my work in Zimbabwe. So in terms of strategy, first step is we started with the assessment, needs assessment of unmet physiotherapy needs of palliative care patients. We started this in 2017. And we did a multi-method observation, including, since internet unstable. Are you able to see me? To see the presentation?
Yep, we see it. Yeah.
Okay. Saying that internet is unstable. So anyway, multi-method approach, including doing observation, going to homes of patients to see them, as well as going to the private and the major government hospitals in the wards where we see patients with serious illness or terminal illnesses. And then we had a focus groups setting where as island staff, multidisciplinary, mostly nurses and social work and physicians, and to talk about different cases of the patient presentation and how physiotherapy would be helpful and for them to be able to appreciate that. So these findings, we end up doing a report saying that, physiotherapy was essential and missing component in the palliative care. But at the same time, I was aware because when I would meet with physiotherapists, let's say in the hospital, they had no concept what palliative care is or how to approach it or how to work with even cancer patients. But at the same token, there was also a suspicion from other providers. So what is physical therapy doing here? These are people that eventually will be dying, and therefore, what can they add to the mix? Because unfortunately, a lot of times when we talk about palliative care or even hospice care, it's heavily reliant on the pharmacological component of symptom management, heavily, including in this country. Okay. Ultimately, the third step of this strategy was to present it to the Ministry of Health. And I was fortunate enough to invite Dr. Manangazira. She was in charge of the palliative integration, to one of the sessions when I was working with a patient who had stroke and just saw what we can do, the changes that we could make for this patient. And she was amazed, and she was a medical doctor, but has never seen how a physical therapy can work or does work. So that was quite powerful presentation to her, which gave us a good support. And then the process was really pretty simple. I mean, it's really presenting what we do on day-to-day basis in a clinic or in a patient or in a ward, okay? We alleviate pain, improve mobility, and so on and so forth. When you juxtapose that to the common palliative care symptoms, you can see that we have a perfect fit in terms of what we bring to the table, what we can do for the patients. So the outcome of all this is that we were able to get the Ministry of Health, the Island Hospice, as well as hospice. This is an overarching organization in Zimbabwe of all the palliative care. They do mostly policies and not much of a patient care. But they all came on board and say, yes, physical therapy was an essential component to integrate in the Zimbabwe healthcare system right now. And we were able to collaborate with the University of Zimbabwe, the Health Sciences Department. We were able to develop a curriculum to introduce palliative care concepts and principles to all undergraduate students, because the program is still an undergraduate. It's not like a DPT like here. And came up with a 2-day workshop that we did across the major districts of Zimbabwe. So we went down in Bulawayo, the second largest city, up Mutare, and so on and so forth. And of interest is Island Hospice was a potential palliative care demonstration site under the WHO at that time. And pleased to announce that they did win the site as a site for demonstration for WHO. What this means is that what Island Hospice is doing can be, as a template, can be replicated in other resource constricted countries. So what did we learn in this process is that there is a silo approach in everybody does their own thing, you know. The Ministry of Health does its own thing, the university does its own thing, the medical professionals are there, like the doctors do their own thing, nurses. Nobody seems to be talking to one another. And ultimately, if we all believe that healthcare providers were there for the interests of the patients, then this silo approach does not work in terms of overall healthcare and caring for patient, and definitely not in the palliative and hospice provision. So the other lesson we learned is that there is work to be done to overcome what this core tradition, what I call traditional palliative code group, which is your nurses, and social worker, the MDs and chaplains, and to include the therapy component of it. And third is the need for education, general education, both within the healthcare provider and as well as in the public. And to overcome a lot of misconceptions about what palliative care is and isn't, and the role of physiotherapy in that context. Of course, it is underutilized there and is also underutilized here and probably everywhere around the world. And finally, the need for academic preparation and the clinical collaboration. And what I mean by this is that the physicians who are palliative care specialists, they go through a particular training. So do nurses, so do social work. We as a rehab professionals cannot skip that route. I just feel that we're just spinning our wheels if we don't take that component of having a specialized training to become known that you're a physical therapist, palliative care specialist, you're occupational therapy, palliative care specialist. Otherwise, I think it will take us a very long time to be able to be on the table. And provide incentive support. And incentive support, I think, really to provide knowledge and skills that would make us comfortable and make all the other healthcare provider team comfortable with what we can bring to the table. So the key recommendations that we ended up having here is physiotherapy is definitely an essential package in the provision and services of palliative care. We need a foundation, didactic and clinical expertise to address this total person quality of life. We require basic palliative knowledge and skill and mentoring. This is not a step that we can skip. And in context of Zimbabwe, it is included in the Zimbabwe National Palliative Care Integration and the Universal Healthcare coverage. We do need to do more research to look at it, the cost effectiveness and how does that address poverty reduction. And ultimately, if somebody has a question, why, rehab when, the decline is inevitable. But we also have to say that we all deserve to be given a chance and choice to live and die with hope and dignity and comfort. And that's a human right. Thank you.
Great presentation, Lubayna. Are
Thank
there any
you.
questions or comments for Lubayna? Other thoughts?
I'm curious, Lubayna, has there been an update? Do you know any more since then? Like have things changed? Are you seeing changes?
Yes, I mean, the integration, it's what we've done with the integration is that every regional hospital will take all the professions that are there and include them into the basic training of what palliative care is and how to approach it. I wrote a curriculum on what physiotherapy is in terms of palliative care rehabilitation delivery. So now, and the unfortunate part is that there's a huge brain drain in healthcare providers, particularly in Zimbabwe, because they're very well trained, and therefore the shortage of healthcare providers, particularly in Europe, UK, Australia, New Zealand, and the other European countries, and now even in America, is to recruit a lot of these healthcare providers. Unfortunately, of all the physiotherapists that I have trained, there's only a couple of them that are left in Zimbabwe right now.
Wow.
So the question right now is that do we train what we call rehab technicians? These are just, they're not physical therapy, they're not occupational, they're not speech therapists, but these are, it's like post-secondary school, there is like a 2-year, I guess it's equivalent to PTA or PTA program, but it's just an all-encompassing, called rehabilitation technician, is to teach them, because these are the professions that will be hard to be recruited as professionals in developing countries, in developed countries, and therefore they're more likely to remain. And therefore, now the idea is to train them to be able to deliver this basic rehab use. Yeah.
So when you use the term integrate, are you like, just a simple question from my real world experience, are the rehab therapists, any of them, OT, PT, or speech, attending palliative care rounds? Are they more
Yes.
integrated? Okay, that's what I feel like I'm trying to get at, but there's so many barriers to that, Is there one specific therapist that's the palliative care therapist, or is that across the board?
No, the idea is to select a certain, in each region, a physiotherapist that shows interest in wanting to learn more about it. And therefore, yes.
Okay.
Not all the therapists that are integrated into this.
Thank you.
Which I think is more or less what will be here. For those who have interest to be, there will be in there, and those who are not, they can do something else.
Yeah, and I think that is one of the challenges. That's one of the things that, Lubayna, we've talked a little bit about this in the past about the US healthcare system, is that it's a little bit different than a lot of nationalized healthcare systems, because a lot of it is fee for service. And I think that's a major problem, because, there's a lot of non-billable time that really kind of comes around to palliative care. So, for a long time, I was kind of on our palliative care interdisciplinary team at the hospital. And I really kind of had to push and advocate for it to show that it was a cost savings. There were patients when they were having bad days, or maybe they were electing to go on hospice, and at that stage didn't feel like they needed the same level of services that they were before. We could reprioritize that therapist to a different area of the hospital system. But since it's not a direct billable procedure to be at those interdisciplinary team meetings or have some of those conversations, it's not considered quote unquote productive time. And I think that's really where this group can kind of come in, is, when we start talking about, payment methodology changes at the governmental or even the private payer level. I think that's something that is a really important consideration.
The physicians are able to bill for palliative care?
I don't know. That's a good question. Anyone else know the answer to that?
Do you mean in an inpatient service and an outpatient setting? What are you, I mean, inpatient, obviously it's bundled.
Yeah, I mean, my understanding is that only hospice services are covered. Anything else in terms of palliative, it's just billed under, your regular, service, like patient is seeing a physician for, shortness of breath, or, so, I mean, they're addressing there isn't palliative coverage per se. Am I incorrect?
Yeah, I don't know the answer to that, unfortunately.
Carlos could probably speak to the hospice side of it, but if you're talking about the inpatient side, you're right. It's bundled. It's bundled into a DRG, right? Or
Yeah, I mean, hospice, I know everything is covered, and it's
right.
covered very
Well, not here. It's not. I mean, rehab is not covered under hospice here, and it's a
No. I mean, if it's hospice, I mean, if a patient is a hospice patient and a rehab personnel goes to see them, they're not covered?
No.
It's a service that
Bundled.
should be, it's a service that should be provided based on the regulations by CMS. PT, OT, and speech therapy should be provided to a hospice patient, but there's no additional reimbursement. So the hospice gets their per diem rate for each day that they see the patient, and the hospice is supposed to provide whatever the patient needs, whether it's medications, supplies, medical equipment, the nursing visit, the chaplain, the social worker, and the OT or the PT as well. So, but it's not separate reimbursement. It's bundled, like Anne said.
You're absolutely right. Yeah, and then I think that's the problem, is that if we involve a rehabilitation for that day, I mean, say it's, I think it's about $200 for the visit. If normally you have $200 to go between, nursing and medical supplies and medications and a home health aid, if you put rehab in there and we take $50 of that $200, now that means there's only $150 for all of those other things now. So it's not like we get more money for doing rehabilitation, which is kind of why I say, even though it's really important to have, rehab in hospice, it's not the best place for it, because the payment structure is not set up for ongoing consecutive rehabilitation. I think that's a major problem.
No.
So there's no incentive for the hospice establishments to include this kind of services.
Exactly.
Correct.
Ironic and sad. I have a very good friend of mine who was on hospice from breast cancer metastasis to the bone. And she took herself out, and I totally supported her because she said, the evaluation they charge her, like just a nurse going to the house, is like over $4,000. The billing to Medicare, but she couldn't get anything. She wanted physiotherapy. They say they couldn't get it. And so she took herself off. So I've been, doing physical therapy for her. It sounds cruel.
It is,
Yeah.
I agree.
Well,
Lubayna.
and that's one of the issues, right? I mean, I think here within the work that we're doing at Providence, but this is only Washington State. We have 3 hospice ministries within our state, in Seattle and in Everett, 2 cities in Washington. They've had OTs for a long time, and they provide the service. I just hired my first OT here in Olympia. So now all of Washington Providence ministries have OTs on staff and provide that service to our patients. Because I mean, and you were saying, what's the incentive, right? It is a regulation, so you have to follow it. And I wish that there was and we're trying to see what can we do at the national level, at the federal level, right? Can we how can we mandate, that agencies follow the regulation? I mean, there's a survey that they have every so often. Surveyors go to that agency and they review the records. And one of the things that they ask is, do you provide therapy services? But usually what the hospice will say, yeah, look, I have a contract with a home health agency, and we provide home health, PT, OT, speech, whatever. But my pet peeve with that is that, well, the surveyor should ask, how many times have you sent a therapist out to see a patient in the last 3 months? I wish we could do more. I mean, some of the work that Emily, the student who's on the call today, is doing is, and some of the other students too that I've had in the past, proposing to CMS to ask questions as part of the CAP survey that the family gets after the patient passes. Did you receive therapy? Was it offered? Anyway, there's different things that we're trying to do. But yeah, I mean, in the work that I've done in the last 17 years, it's been like a handful of places that I've heard of in the country that actually provide therapy services or have therapists on staff.
Yeah, I'd like to chime in, Carlos. Hi, because I was at Providence and now I got hired by a different hospice agency. And the route that I was hired, they wanted to have a staff OT because they heavily use their rehab department. They send out OTs or PTs, and some of the OTs, PTs followed their clients from palliative to the hospice setting. And the director of our hospice, she really noticed how great it was to have that continuation or just have a therapist available on staff. I feel sad for your friend that didn't get that input. And I think in the future for any of us, when we have a client or someone outside of our life that is on hospice and wants therapy, I think we have the language to demand it from the agency. No, you have to provide this. We're asking for it. And they will, like Carlos said, they will be cited if they don't have a proof that they can or that they would.
But you have to,
yeah.
the budget has to be there too, right? I mean, the money has to come from somewhere, so.
For sure.
Yeah,
The agency that I work for has a lot of money, and that's why they were able it's a kind of a more private or a smaller agency and with a lot of community funding. So they were able to make that step, and we're all hopeful that it can expand further to other agencies. But I realize that the for-profit hospice agencies will never get to that level. That's not there.
So, this is a great conversation. Yeah, the other thing that I am aware of too when it comes to hospice payment methodology is that it's kind of weird because something is not covered, rehabilitation in an outpatient setting is not covered if it's part of your primary condition. But if it's something that's completely unrelated to your primary condition, my understanding is that it is generally a coverable service. So for example, and I'm just going to use a couple of crappy examples here of someone has lung cancer and they're in hospice for lung cancer, but they sprained their ankle and it was completely unrelated. They were walking down the street and they just twisted their ankle. They can get physical therapy for that under their normal health insurance benefits. But if it's related to, okay, I sprained my ankle because I was weak and I have poor proprioception, or I have cancer or chemotherapy-induced peripheral neuropathy, it's kind of related to their primary condition, so it might not be. So there's a little bit of the documentation that kind of falls into that as kind of the why. And I don't know kind of some of the nuances of that, but I am aware that that is a payment nuance that might be able to be utilized by others. So if other people have more information about that, that would certainly be welcome as well. So one other thing I did want to share, and we'll make sure that we start wrapping up unless other people have any other comments or questions. I am aware of where did it go? I just had the link up. There is a virtual institute, and maybe I can even just share my screen so you guys can kind of see this as well. That's okay, Lubayna, I'll steal screen sharing from you for just a second here. So you guys should be able to see my screen. There is a Learning Health Systems Rehabilitation Research Network, and they have a virtual institute. And I think it's free. I am going to be going to both of them. It's Rehabilitation and the Management of Chronic Conditions. And this was co-sponsored by COSTAR, which I think is the American Physical Therapy Association, and other rehabilitation researchers. So you know, I'm going to kind of make sure that I'm there speaking to the, you know, kind of to the palliative care, because, you know, some of these care of chronic conditions are very early stage, especially when we're talking about rehabilitation. And it's going to have health systems, government agencies, funders, professional associations. So I'm going to be there, hopefully making sure that our voice is there, kind of speaking to this, because again, this is where funding comes from, and this is where researchers are really kind of going into. So if you have time, I'm going to put the link in the chat, and then I will also let me put that to everyone, and I'm also going to put it on the front page of our website. I realize it's a few weeks away, but hopefully you might be able to kind of spare an afternoon or part of an afternoon to potentially do that. And again, hopefully if you guys come across stuff like this, please send it our way so we can post it to others. We'll probably be posting it to the, you know, onto the web page, but also kind of starting to work on a little bit of it like an email blast or a newsletter blast or something like that periodically. So kind of starting to work a little bit of the infrastructure out there a little bit, so that we're all aware of some of these offers. So I'll stop sharing here. So hopefully you guys can come and join us for that. So any other comments or questions or thoughts? Anything else we want to make sure that we're talking about today? This has been a really, really nice session. Lubayna, thank you so much for sharing. I think what you've done in that area of the world is really inspirational. I think it can help lend some great lessons of kind of breaking down some silos that this group I think is really focused on. So thank you so much for sharing that. And so Annie, any other last minute words of wisdom or anything else we need to focus on?
You know,
Please consider nominating yourself or someone to our steering committee too.
I just have a quick question for the folks out there. We've just developed at Georgetown an outpatient palliative care, and rehab is not involved in that. Does anybody do that? Does anybody know? Because I assume we could bill just regular old billing if it's not hospice. I don't know if anybody's doing that or has any thoughts.
We do have, I mean, at Corewell where I practice, we do have a palliative care. You know, it's not necessarily specific, but I mean, it's just where the palliative care team refers to us.
Mhm.
And it's really good old fashioned Medicare Part B.
Yeah,
in that
yeah.
setting.
That's what I
So
would think.
palliative care payment policy does not change. And
Right.
yeah, and in the inpatient setting, we did a survey a few years ago at Corwell Troy. And we were already on 80% of the palliative care cases.
Yeah.
So
We were
it's
70%
not a
when I did it,
new,
yeah.
not a new service line for us. So Mac, how you doing, buddy? Good to see you.
Doing great, doing great. Sorry I didn't show my face during your presentations and stuff like that. I just wanted to chime in. My name's Mac Ivy. I work at MD Anderson, Houston, and I'm an occupational therapist. What they do here is they call palliative care outpatient, especially they call it supportive care. So then it supports whatever their main diagnosis and their main team is following. They support and they work on symptom control. And so then if someone needs OT or PT outpatient, then they come in, like you mentioned, just to the regular OT, PT. But
Okay.
you mentioned a good point. Our outpatients aren't really skilled as much with end of life situations. And like I was in a patient's room today and he was just had surgery 2 days ago. And he's already thinking this might be it. So we talked about his bucket list, so it's never too early
Mhm.
for people to explore, what's important to you? What can we keep you doing?
Mhm.
Reprioritize. Sometimes need to simplify, stop doing some of the things that you don't need to do anymore and focus on the things that are really important. So that is an opportunity. Maybe I'll explore it here and see if we can work on helping those therapists, OTs and PTs be more comfortable with those situations and conversations.
And one of the physicians that's been on before, I don't see Tim on here, he does some of that, some training on using that language and, how to, the difficult conversation language that I think for some of us is easier than for others, but making everybody comfortable in that space so they can really explore person-centered values and stuff. Yeah.
Exactly. That's what we all should be doing.
Oh, yeah.
I think that is where the formal training is required. We can't just ad hoc do the thing that we think is we're good at. So it has to be. We have to understand the principles behind it.
Exactly.
And all be the same page, whether you're a nurse, a physician. I mean, you all know everybody's role and supporting each other in the ultimate goal of making the patient and the family most comfortable.
Quality of life. Yeah.
Yeah.
Mhm.
Exactly.
Well, it is almost 8, so I want to respect everybody's time because everybody is so busy. I want to thank everybody for joining and thank you, especially Lubayna. And anything else, Chris? Or we said June 7th, right? Mark your calendars now.
We'll do June 27th. And if you're available, if we know you, there is a risk we may invite you to. So, and just a hint, we just had a physical therapist speak, so it probably won't be a PT. We need to break down some silos. So
Carlos. Yeah, we know everybody's busy, but we would love
Agreed,
to just have everybody, at some point, just share what you do because it stimulates what we could be doing better at our facilities, So.
All right. Well, thank you, everyone. And we're going to post this online in the very near future. So you'll get a recording that you can share with your colleagues. So.
All right. Thank
Have a
you.
great night, everyone.
Thanks,
Good
all.
job.
Thank you.
Bye, gang.
All right, bye.
Thank you. Anne?
Yes,
Congratulations, Anne.
Oh,
wanna-
thank you.
Nice
I'm
work.
done. I'm
Nice work.
done.
Yeah, good
Yes.
for you.
Yes, no, big deal. I'm glad to be done. Thanks. Bye, Marlena.